purely no prep veneers in patients with zero inflammation signs, with a super top oral hygiene, who come every 3 months back to the office and do a dental hygiene cleanup. Because it's like, it's waste of time and a waste of energy, and for the patient it would be a waste of money if this would not be completely compliant and adjusted to the big effort and the that he or she is receiving. And question number 5, is my dental technician skilled enough to produce the right work? And if the dental technician, and this is a reason why we address not only the dentist, but we want to share these days, this course together with the dental technician. It doesn't make much sense if it's purely the dental technician showing up or the dentist is showing up. It would be the best form if the dentist comes with his dental technician, because everything is matching together, everything is fused together, and it is so important that here begins the communication. So what would be the checklist previously for a treatment would be, for instance, is there any ortho treatment necessary? If teeth are too crooked, or if there is too big gaps between two teeth, that would cause two big differences in the thickness of the veneers, even if you would do no prep veneers. So the best aesthetic match you will have is if the teeth are plus minus aligned in one bowl. Very little correction still are demanding, because if you have one tooth a little bit more in the back, one tooth a little bit more in the front, you need to adjust all the optical phenomena to this. So the material thickness is thicker compared to the one that is in a correct position. Translucency is different, opacity is different, the hue is different, the value is different. So we can adjust this with different cement colors or composite resin colors, but better sometimes is to do some very little corrections, adjust, align the teeth within 4 to 6 weeks if it's very little, and then start with the no prep veneers. In the majority of the cases that we do bleach prior to placement of the veneers. The reason is pretty easy. No prep veneers are the thinnest that you can find, because we do not prep. Simple as that. If we do not prep and we don't want to create very thick veneers, they need to be very natural. And if they need to be very natural, they're super thin, between 0.1 and 0.3, max 0.4. That's like super max, the maximum thickness. And since then, the light passes very easily through this very thin veneer, we want to have like a grounding surface, a light color. So if somebody has an A3 color, for instance, we go to an A2. If somebody claims to have super white teeth, like a A0 or a bleaching color, then for sure we need to bleach, because no one has by natural a bleaching color of A0 or a bleaching color. Do we need to adjust the gingival margins? Sometimes, yes. I would say in 60 to 70% of my cases, I need to adjust it. How do I do it? I take a diodium laser. I do correct the outline, that we are able to shape the teeth in a proper dimension. And then we need to check if we do have a violation of the biological width, yes or no. If yes, I do some correctional surgery with an ultrasonic device, with piezo surgery. If no, we just can leave it like that. How's the occlusion? We do we are able to place no prep veneers in grinders and bruxers. That's possible, but we need to follow specific rules. We need to adjust it to the situation. We won't turn a bruxer or a grinder into a non-bruxer or a non-grinder, but we can adjust our restoration to the situation of the patient. So we need to check, of course, the occlusion. And of course, if there is power functions. All right. When we use the tools like imaging to show the patient what would be a possible result. There's a numerous, a vast, complex, like a number of different systems. One is here, for instance, Envision a Smile, the Coachman DSD, digital smile design is very popular. There is some others like Visage Smile, where you can shape, where you can communicate with the patient, what is possible, what is the need, what is the wish of the patient, and so on. And there is some very bad ones, like this Easy Smile, because it looks like super unnatural. And one very big challenge is that if a patient, let's go back, is seeing something like that, the result that was created by Envision a Smile, and says, okay, I love that, and takes a picture of that, you need to achieve that. So sometimes it can be a benefit for communication, sometimes it can be a pitfall. So this is something we need always to keep in mind. So this is a very bad example of a smile design tool. So probably you follow another way. It would crush my time to talk about proportions and symmetry, but as we know, there is some rules that we find in the aesthetic perception of natural teeth. And nature is by far the best copy that we can find. So there is typical relation due to the golden proportion that we find in the face and that we find in the dental structures as well. And if a granny has like the wish to change her completely and she wants to switch herself from the left picture to the right picture, as I said, communication is so important. It is questionable what looks better or not, but she is happy with the result. And we need to understand, of course, primarily the needs of the patients. So how do we communicate? And I like, even in times of very digital dentistry, I like analog dentistry still, because it is still there. And this is, of course, showing the capacity and the ability of the dental technician. And of course, you have something in your hands to show the patient. So if we talk about wax ups, I want a wax up that is looking like this. It should be in a nice color, in white wax. All the structures should be visible. It should be like done very, very properly. I'll show you later a very bad example. Or in the lower, for no prep veneers in the lower, this is a beautiful, very perfect wax up. So what do we do with this wax up? A, we use it as a cast to find like the right dimensions and to put it in the articulator and to check how is the bite situation, can we deal with that? Number two is, based on that, we can create a silicone key, to find out what would be a maximum thickness, what would be an appropriate thickness of our veneers. And if we are communicating this with our patients, then you can see, okay, my teeth are going to be longer or wider or whatever. So that's important. Sometimes we can evaluate even partial veneer possibilities. So here, this is an example with green wax, just to show, okay, this could be, this is a very, very nice example how tiny those partial veneers can be. And they are very, very fragile, and cementation is pretty demanding. A diagnostic wax-up sometimes is necessary in those cases where you find disclusion. So sometimes we figure